infraclavicular blocks. The infra and axillary are both blocks that do not block the shoulder. So they share that. But one is a plexus block, the infraclavicular block, because it's a block done either at the divisions or at the cords, usually at the cords. But you can do it at the divisions, as I hope to show you in a few minutes. The axillary block is a block of terminal branches. Now, in general, as you move the injection point from central to the periphery, the block is going to last less and less and less. So although it's very tempting in analgesia to single out a nerve, for instance, a patient had an isolated finger injury and then the patient is in pain and you want to do a pain block, then it could be like tempting to do just that particular nerve. You could do it as a temporizing measure. You know, it will give you some time for the patient to start taking his analgesic or oral analgesic and have time for them to work. But it will not last long. So if you inject bupivacaine, for instance, in a digital block, don't expect to last hours. You know, however, you inject the same bupivacaine at the supraclavicular level, you could get, 12 or more hours of analgesia or anesthesia, depending on what you're looking for. So now the infraclavicular approach was introduced by Bass in 1917 and Labat, soon after in 1920. This from Bass, this is from Labat, but it was forgotten, and it was the accumulation of pneumothorax with the supraclavicular that make people look for other places, other ways of doing blocks. So one of them was the axillary first, but the axillary people felt not grown up doing an axillary. It was just, not too close to where the danger is. Nobody was, killing anybody in the axilla. So they wanted to get a little higher, and higher was the infraclavicular. And notice that infraclavicular does not exist in the anatomy. There is not an infraclavicular region, since the infraclavicular is just the anterior wall of the axilla. You can enter the axilla through the anterior wall. But we call it infraclavicular, and Rush reintroduced it in 1973. And notice that this was just a complicated way of doing an axillary, because he will start below the clavicle, but he will direct toward the axilla, so his injection will be in the axilla. So a complicated way of doing an axillary block. And you can see here the actual needle and so on and so forth. But a true infraclavicular exists at this point, and usually we think infraclavicular is a block of the cords. The cords now are surrounding the axillary artery, and we go lateral, medial, and posterior, and that's what we want to block. But again, a little bit of anatomy. If you look at the plexus as it arrives to the infraclavicular level, and I hope to show it in another instance here, vein, artery. Notice how the cords get to form lateral to the artery. And so it's not a transition from the supraclavicular that is, miraculously into three cords. It's a transition that happens slow. So there is an area where the brachial plexus is below the clavicle and is ordered just like in the groin, vein, artery, nerves. So the nerves, the cords, the origin of the cords are all lateral to the artery. And notice that the insertion of the pec minor, I cut it there. This will be the apophysis, coracoid, where the muscle inserts. So this area will be only covered by the pec major. So this is another dissection where I cut below the clavicle just to show how this artery there, that's the vein, in the package of nerve produces an image that is very similar to supraclavicular. So notice that the infraclavicular, the main indication would be to put a catheter in the upper extremity, other than a catheter for the shoulder, because the supraclavicular, although would be good, it's just too superficial, too flimsy, too easy to accidentally dislodge. So here, if you were looking for a place to put an infraclavicular catheter, putting it into this package, as opposed to dealing with the cords that are surrounding the artery, it makes a lot more sense to me. And I call it, when I created it, I call it proximal infraclavicular. So here you see the video. I hope the video is showing here. To moving. Okay, so I'm doing it on myself there with a butterfly IQ. So there is the vein, the axillary vein, the axillary artery, and if I keep going lateral, so this is pec major here, and there is the package of nerves. You see how easy it is to get that image in would be a infra made easy. So the needle insertion would be from usually from lateral to medial, but you could do it. You could do it with out of plane. This is one of the blocks where out of plane would be having advantage, but we don't have time to go over that. So needle insertion and injection into that. I published this in 2008, although in my own manual, in the first edition, I was already listed as a possibility. But how things go. This was repackaged just recently in 2016 with no mention of this previous publication, and the same thing was reinvented, and it's called now costoclavicular. So either you call it costoclavicular or proximal infraclavicular, the concept is the same. In who owns it, it really doesn't matter, because what it matters is that below the clavicle you have the same that at the groin, vein, artery, nerve, and you could, with the arm in a slight abduction, do an infraclavicular transverse right below the clavicle with the concept of the compartment without having to go around the axillary artery. Now, but if you still like that one, then it would be a little deeper, because now you will have to deal with whatever thickness of the pec major and pec minor have in that particular patient. But it's also an easy concept where you will have pec major, pec minor, and the axillary artery, and then you have the lateral cord, the medial cord, and the posterior cord. Notice that the posterior cord should be called a posterolateral, because it's not true posterior, it's behind the lateral cord. So my idea is that because the lateral cord is the one that you always will see much easier than anything else, is to go directly and do that first, to inject in the lateral cord. And once the diffusion happens, then the rest become more notorious, because you are providing a dark background to the image. So instead of trying to establish the presence of all three cords, which sometimes is possible, but if it's not, I'm saying or suggesting, inject around the lateral cord and then see what happens, because the lateral cord will usually, the injection around will illuminate your path for the rest. So here you see the needle coming to the lateral cord, and the idea would be to distribute in a form of a U, so to reach this other side. Now, if the local doesn't do this, notice that it might be your experience too, that in younger patients, there's less adhesion, so the local anesthetic travels far and opens planes very easily. But in older patients, there is more adhesions, and it's more difficult for the local to travel a certain distance. So sometimes you will have to remove the needle from there and go directly to the other side of the artery to do your medial cord. Now, the medial cord most frequently is located between the artery and the vein, but sometimes it's on the other side of the vein. So, you will have to then take your pick as to what is happening. In this case, one injection is doing the whole thing. As you can see how the injection started there, actually reach all the way to the other side as a U. So that can be obtained in some cases. Now, there is a, as I said, this is ideal to put a catheter. I'm not going to refer to the retroclavicular approach, which is an approach that people are doing by putting the probe over here and then introducing the needle on the supraclavicular level and passing under the clavicle. The advantage is that when the needle reappears in the infraclavicular space, it's parallel to the probe, so it can be seen very easily. So it's tempting. There will be a blind spot where the needle crosses under the clavicle, you will not see anything. The problem with that approach is that ignores that the suprascapular nerve crosses there. And so it has been now acknowledged in the literature that a suprascapular damage is possible in this technique. You will encounter the suprascapular nerve behind the clavicle in the area where you're not seeing the needle. So when the needle reappears, you already have done your damage, and now you can do all your beautiful block on the other side, while, maybe the suprascapular is, cheese kebab in the, in your little skew there, or whatever. So let's not do that part. In the axillary, I think it's easier demonstrated, as we have had a few in the last few days with some of you. It's just fun to direct the needle to different nerves. Keep in mind that for close to 30 years, I used to tell people, always when you do an axillary block the musculocutaneous nerve, because you don't want the patient to keep the ability to flex the elbow during surgery. Patients, most of our patients are not risk for getting a Nobel Prize anytime soon. Sorry for saying that. But they will feel an itch or anything, and they might try to bend the operating arm and try to reach for that itch. And that was always theoretical until I saw it with my own eyes. I had a meeting across the street, and somebody else did a block for me. And when I came back to re-own the block was the moment when the patient hit Lamberti on the head by bending the arm that was the operating arm, and he wasn't happy. And now all of a sudden is my block. And so it does happen, maybe once every 30 years, but it does happen. So block the musculocutaneous, because it will improve the surgical conditions of an axillary block, whether that block is important for the surgery itself or not. So start with the musculocutaneous. But the image that I wanted to show you is the image of the conjoint tendon. So this conjoint tendon, which is the latissimus dorsi and teres major, will break the monotony of the image on the axillary. So you put the patient in abduction and then put the probe across, mid-humerus, and then move it up and down. It's very boring because it has two channels. One channel is flexor, one channel is extensor, and the channel in the middle is neurovascular. Very little things change. A vessel joins another, or the branch comes out, but you go up and down, and nothing exciting. So muscle, neurovascular in the middle. But if you go high enough, and that high enough is usually when the probe reaches the passage of the pec major on top to insert in the humerus, you will see that a muscle passes from one side to another, breaking the monotony of the image. That is the conjoint tendon. And the conjoint tendon, which is, I should get a video of that, but here is the conjoint tendon, will help to frame the image. It will provide a floor to the image, because now the image that always had lateral, medial, and superior wall, now it will have an inferior wall, which is the upper edge of the conjoint tendon. And when you get to the conjoint tendon, you will realize that the axillary nerve, the radial nerve, which is a large nerve, but it's difficult to visualize because the window of opportunity is very short before the nerve turns behind the humerus, is very easily identifiable there when you just realize that the nerve lies on top of the conjoint tendon. So now you know that everything that matters to you will be on top of the conjoint tendon. There will not be anything below that. So that's what I call framing the image. So, and there most likely you will see musculocutaneous in the same image, so you will be able to do all your blocks in one single, from one single entrance. So you see here the needle entering to do the radial, to do the musculocutaneous, to do the ulnar or the medium, and in that, as I said, can be done all of those nerves at once or focally according to what nerves you need. So I know this has been kind of a marathon, but I hope it kind of gives some valuable information, and at the same time, for those who like regional anesthesia, get to be excited to learn more and more in our way to make regional anesthesia the practice of a science and leave that art behind. Because although I'm very artistically inclined, the exercise of medicine is the exercise of a science, or should be based on facts, and that way you will get results that are reproducible. And that's what we owe to our patients and to ourselves. So thank you very much for your attention, and I will entertain a few questions if you have.